Good morning. I want to thank everyone for inviting me and welcome to DC. We have three big meetings here this year, the SUO, the AUA, and the focal meeting, so this has been a great year. My talk is to try to go through the indications for ablation of kidney masses here, and I think the general indications that nobody will argue are peripherally located solid tumors, where the estimated ablative zone must be free of non-targeted structures. In other words, you can't be ablating things you don't want to ablate. Patients with medical comorbidities, including age, life expectancy considerations, need for anticoagulation, or people with significant risk for hilar clamping. But I want to go here, and we talked to Phil's lecture earlier. All these patients you look at, you have to really strongly look, are these patients that could be otherwise considered for observational or active surveillance? So when you look at these patients, before you rush to doing this, these are patients that should be considered for active surveillance as well. The options are open, laparoscopic, and percutaneous, but I think what's happened is that laparoscopic and open have dropped dramatically as less invasive approaches come around, specifically percutaneous. So really the rest of the talk is going to focus more on the percutaneous approach because I think the other ones are not as widely practiced nationally. If you look here, this just shows how little, most of the laparoscopic ablations were done by urologists. The bottom line is the ablation line. The top line is the total number of cases treated. And you can see that amongst urologists, despite the number of cases increasing dramatically, the number of ablations have decreased because urologists really aren't doing the percutaneous ablations in most places. What are the consensus recommendations if you take the EAU, NCCN, and ASCO and AUA? There's some subtle differences, but they're all pretty similar. And really, if you look here for the EAU, they're very strong about saying surgery is the only curative treatment for localized renal cell carcinoma. This was updated in 2019. They did talk about ablation for elderly patients with comorbidities, patient with genetic predispositions, or people with bilateral tumors, but they were pretty strong on how they felt about ablation, at least at this time. NCCN, once again, feels strongly about active surveillance or thermoablation for selected patients and less surgical excision as the treatment of choice. The ASCO guidelines, once again, partial nephrectomy is the standard for small tumors, and ablation should be an option for those only where you can get complete ablation, not as a palliative or a reductive type of situation. The one that really, I think, has actually incorporated ablation into the guidelines is the AUA guidelines. And they updated in 2017 based on new data to show that this is an alternate approach for CT1 ablations less than 3 centimeters. And they endorse the elective use unlike the other 3 guidelines. They strongly recommend percutaneous over surgical approaches due to the increased morbidity and just the idea that you should be counseled about higher recurrence rates. Where did these guidelines get their data from or initial recommendations? This is one of the earlier studies out of Boston, multivariate analysis of their series, and it came to several conclusions. One, that small tumors were viable, especially peripheral. Larger tumors possible, but may require multiple sessions. And the concern of ablation of endophytic tumors in their series, they were worried about the heat sink and worried about the complete ablation possible. This was a great study that Phil did on meta-analysis of 107 studies in 2016, found similar cancer across different modalities as far as survival rates. However, they did note that there's differences in renal function, perioperative outcomes, and postoperative harms, especially with surgical approaches, partial nephrectomy. So one of the things that comes out of this is that for small renal masses, radical nephrectomy is probably not a great approach if there's significant renal function impairment afterwards, especially when there are other options available. This is a great study from the National Cancer Database, over 50,000 kidney cancer patients. Similar outcomes, percutaneous ablation provided similar cancer outcomes with lower risk of renal failure and periprocedural complications. So that's going through where the guidelines are now, how we got to those places. What are some expanded applications possibly for percutaneous ablation beyond those? Well, one thing we learned is that ablation following a failed ablation is the usual now and acceptable. Studies have shown that you can get very acceptable rates, especially larger tumors, with a repeat ablation without significant affecting cancer survival rates. So if you take that into account, it may give the opportunity to treat larger tumors. And as I said, this is from the meta-analysis that was performed on the multiple studies. How about renal ablation following partial nephrectomy? This may be an expanded application. The only place I could find that actually addressed this of the guidelines was the EAU guidelines, and based on their data, they said that this probably should not be performed. You should offer surgical resection of locally recurrent disease when feasible. But I have to say, I've done a few cases myself. This is a case we did recently. To the left was the original renal tumor. The next one is the first postoperative follow-up, which was completely negative. The third one is 1 year later, showing a local recurrence in the resection bed there. You can see the last one was the ablation and the post-ablation imaging there. I think we may see an increased role. There's not much data on this, but I think there is maybe a role for some patients for this. As far as expanding the applications beyond the small peripheral tumors, three things that we can look at are larger tumors, endophytic tumors, and interposed organs. The big concern about larger tumors, this is the most recent Mayo Clinic follow-up of T1 lesions. They broke it up into T1A and T1B. And what you'll see here is for T1A here, there's, as far as survival, there's very similar survival between the two. But if you get to the T1Bs here below, T1As is the lines are equal. There's a separation between T1A and T1B as far as cancer-specific survival, raising the question of whether we're putting people at risk with larger tumors with ablation. Needs more studying. As far as endophytic tumors, another study here that talks about endophytic tumors. They found that they could be done successfully, but there was a much higher complication rate of 10%, which is higher than you would expect compared to exophytic, but once again, looking for expansion to endophytic tumors. And as far as interposed organs, there are very few tumors that can't be treated percutaneously now. This is a case we did 6 months ago. The bowel on the left was sitting right next to the tumor. We put some saline in there, got some distance between us, and treated us.
Come to an end. Sorry.
Yeah, yeah.
Okay.
So, just to finish up here, percutaneous ablation has increasing role with the treatment of appropriate tumors. Patients should always be considered for active surveillance. Endophytic tumors possible, but higher complication rate. Some questions as to efficacy with larger tumors, and what we really need are some good trials which include active surveillance for defining the role.
Thank you very much.